what we are going to discuss is when you're looking at in patient's mouth, when patient comes for a checkup, and when you're looking for the teeth, what type of cases you should look for, and what type of cases would qualify for full mouth reconstruction. Now, this is basically a case-by-case selection. So, you you need to really decide on a case-by-case basis. But I just want to discuss a few examples. So I have 18 cases, which I'm going to show you, just a pre-op, one slide with all the photos per case, just to keep things simple. So you get an idea. So when you look at a case or when you're doing checkup, you can literally tell there and then that, yes, this patient needs probably a little bit more investigation, and this patient probably needs full mouth reconstruction. So let's start straight into the case. So let's look at the first case. So this patient came to see me because patient had already had some actually build-up done. You can see residual composites on the upper anteriors. So he had upper and lower build-ups done, and he chipped everything within 9 months. So you can tell that this patient has a wear. Majority of the upper teeth are restored, and they need some sort of a treatment. Porcelain crown is chipping. There's exposure of the metal, retained root. The crowns, the metal crowns at the back, they're not too bad, but possibly may have some marginal caries. You can see in the photo number 1 on the top left. Lower arch, lower anteriors are quite heavily worn down, and lower left 5 again is temporized using GIC. Lower right 5 was actually a new crown, recently done. And this is what I see a lot, where dentist has done a crown, which is newly done, and patient needs full mouth reconstruction. Now, it's a very difficult conversation to have, especially when you know the dentist and you know that they're good dentists. It's very difficult conversation to have with the patient that, oh, now I need to do full mouth reconstruction. And because of that, I need to increase OVD. When we increase OVD, we basically are going to end up restoring every single tooth or redoing every single crown. And it's not a nice conversation to have, because patients already just paid a few months ago for this new crown. So make sure that when you have this sort of cases, again, because the number of teeth involved and the kind of amount of wear, you can tell that this patient needs full mouth reconstruction, upper and lower arch. Now, in this whole discussion, when I am saying full mouth reconstruction, it could be single arch, it could be double arch, or it could be combination of ortho and partial reconstruction. But if you think about orthodontic treatment, it is a type of reconstruction. You are moving teeth around, you're changing occlusion, you're changing bite. So orthodontic would be considered as a part of full mouth reconstruction. So the next case, again, it's a very clear case. This one, patient has a severe tooth wear, and you can see that the upper right one is actually had enamel sort of veneered off. So patient's enamel just chipped off completely from the buccal, half of it, buccal wall. Again, you can see that multiple of teeth have got severe wear, upper and lower. Patient's got old restorations, which are, even the crown has got porcelain exposed on the upper arch, heavy, large amalgam, edentulous areas. So again, when you look at the teeth, number of the teeth needing treatment, they are more than 90% of the teeth needs treatment. And again, this is a clear-cut decision that this patient needs a full mouth reconstruction, upper and lower, replacement of the missing teeth via either implant or using denture. When you are doing full mouth reconstruction with the denture, most of the time I do dentures, well, all the time I'll do denture right at the end of the treatment. However, sometime I would have planned occlusion on the denture. So this is a case where sometimes you get a class 2 div 1 cases where patients got really severe anterior overjet, and you can't really even do ortho to correct anterior open bite. In that case, sometimes when you give patient denture, you can have this metal platform on a denture to guide lower anterior and kind of build up anterior protrusive guidance using denture. But otherwise, denture will come right at the end after you've done the full mouth reconstruction. Now, this case is not so straightforward. If you look at the case, yes, patients got wear. Should you do a full mouth reconstruction in this case? Because, it's a young chap. This patient was a 28-year-old, and I saw him. And his main concern was upper anteriors. He wanted aesthetics to be better, whiter teeth, but he wasn't having any sensitivity or anything. However, another criteria I use, the first criteria is how many teeth needs restoration and how many teeth have got severe wear. The other criteria I use when I am deciding whether the patient needs full mouth reconstruction or not is number of exposed dentine. So number of teeth with exposed dentine. Now, if you look at this case, you can see that almost all upper teeth, apart from the teeth with the crowns, crown and amalgam, they all have got wear, and I can see there is exposed dentine in all of them. Upper left 7 doesn't look like it's got too much wear, but that's an exception. The rest of them has got a lot of wear on the upper arch. Similarly, lower arch, posterior teeth specifically has got a lot of wear. However, you can see anteriorly a little bit small chipping in this case. Now, this case, treatment plan wise, would be a little bit tricky because you don't want to add too much to the teeth. And as we know, we want to add around 2 millimeter or the bulk of the composite to be present. Now, if you are doing indirect veneers, then yes, you'll have to do prep in order to do veneers. Obviously, it will all depend on the diagnostic waxer. But nonetheless, this case is a full mouth reconstruction case. And this case was treated with orthodontic treatment and direct composite for full mouth reconstruction. But again, when you see this case, initially, sometimes you think, oh, I'm not sure whether this needs a full mouth reconstruction. When you look at exposed dentine, how many dentine is exposed? Now, the option is you could leave this as it is. The problem is the dentine will deteriorate over time faster than enamel. And he's 28, and if you leave everything as it is, maybe when he's 40, he will need some reconstruction. The problem will be at that point is that his bite would have collapsed because the teeth will not lose contact. The occlusal plane will be uneven, and there will be dentoalveolar compensation, because when you have wear, usually we know that unless the wear is really, really rapid, erosive wear, you don't get reduced in OVD. You have the same OVD. It's just it's get compensated by dentoalveolar compensation. So again, to me, this is a full mouth reconstruction case because of the number of dentine exposure and posterior severe wear. Again, upper anterior has also got quite a lot of wear in this case. Next patient. So this patient here came to see me because he had his anterior teeth, which were quite chipped, and he didn't wanted to improve aesthetics. Now in here, you can see that apart from upper and lower 3-3, where you can see wear, upper posterior teeth are not terribly bad actually. And the lower anterior, yes, they have a wear. The occlusal plane is pretty straight in here. And patients got this habitual class 3 occlusion, so edge-to-edge occlusion. And that's why you may find sometimes it's difficult to gain space. Now, in this case, you can approach this two ways. You can do orthodontic treatment and move lower anterior teeth inwards, considering periodontal health, if they're healthy, or you can just restore them in edge-to-edge position. You just need to make sure that the incisal edge is a little bit thicker when you do that. But you could potentially get away by just restoring anterior teeth. The problem is you can't dial this case because we all agree that the anterior teeth needs restoring. Problem is when you are when you restore those teeth, you will, because it's class 3 edge-to-edge occlusion, and assuming that that's his occlusion, you will inevitably raise OVD. Now you can leave it as it is to dial. However, there are not that many teeth, to be honest, lower teeth, which are in contact with the upper teeth. So, 10 teeth. So I would be inclined to really restore all the teeth and treat this as a full mouth reconstruction case. Although you could get away without it, if that makes sense. But it may be just easier to just restore all the teeth with direct composite in order to create that. Okay, so someone's asking about the dial, but yes, it's the same thing. So in order to create, it will be very difficult to dial this case, basically. So in order to get a better occlusion, again, full mouth reconstruction or anterior reconstruction 5 to 5 would be suitable in this patient. Again, this is a snapshot. Judgment and snapshot treatment plan. Of course, you need to do mounting. Of course, you need to have more assessment. But today's webinar is all about, I want you to look at the patient's mouth and make a snap decision whether you want to investigate this further or not. When you are, what kind of factors you are considering. Of course, with treatment planning on the summit on 11th of March, I'm going to discuss some bit more in detail, the steps and everything. You'll have a much better idea. But remember, I want you to have a single case ready, at least one case. And you just need to have photos like this. Of course, you need to have a smile photos and side profile and all the remaining photos. But make sure you have some photos. And the idea is on the day of the summit, you will be treatment planning your own cases along with me. Now, I won't be able to help you, each and every one of you, to plan individually. And that's why we're going to do a mass treatment planning. This is a group treatment planning session where everyone will plan their treatment. But for that, you need to have a case. And to have a case, you need to know what type of cases you're looking for. And that's the whole point of doing today's webinar. But it will also help you when you start doing full mouth reconstruction, what type of cases to look for. Because many times we think that, oh, patient got severe wear, those are the cases are for full mouth reconstruction. But more time I do full mouth reconstruction on cases where patients got moderate, mild to moderate tooth wear, but it's a heavily restored dentition. And it would help me to raise OVD with the spaces and everything, and the treatment would be very minimally invasive. So, and because of that, I tend to do full mouth reconstruction. There are lots of reasons why you would do full mouth reconstruction apart from just tooth wear. But in this case, as I said, if you could do ortho and you can restore the teeth minimally, or you can do full mouth reconstruction. DAL is not ideal, in my opinion, for this case. Another case, this patient came to see me for implants, actually, for lower fives. She had over-retained E's. They were taken out, and she wanted to replace it. And I asked her, she said, yeah, my anterior teeth, front two teeth are a bit sensitive. She used to drink a lot of Coca-Cola, which now she stopped. And again, you can see that, it's not a very clear-cut full mouth reconstruction case. Yes, her central incisor needs some treatment. There's some blunting of the canine tips. But we know from the studies that, many youngsters, they start out with canine guidance, but, the teeth wear down and they then turn into true function. Now, in this case, again, I will assess exposed dentine. And if you look carefully, all the upper teeth have got exposed dentine apart from one of the 5. And because of that, I decided to do single arch reconstruction. So that's the upper arch reconstruction. And I will discuss this case on the 11th of March. But so I decided to do upper direct reconstruction, and lower I just restored teeth with the old fillings, replaced all with the new fillings, and placed 2 implants. But this again is a case where you may say, oh, you know what, I don't think I want to do full mouth reconstruction. Now, to be fair, on this case, what you can't see is the 2 central incisors, or you may be able to see just about a quite deep notch. So she had a traumatic bite where her lower incisors were really digging into the palatal aspect of the upper incisors, and it had a really big crater there. Along with upper on the photo, the left 4, you can see that the fractured palatal cusp there. And again, there was a lot of tooth wear. So this case was restored using direct composite occlusally for all the posterior teeth, and palatally for the anteriors, and buccally for the centrals. Now, this case here, patient had uneven anterior tooth wear, and you can see again on the occlusal photo of the upper, you can see how traumatic her bite was, that she was almost exposing the pulp. Now, this case, yes, you could potentially treat this by doing orthodontic treatment. However, her lower teeth, as you can see, not the great, periodontally involved. Also, patient did not want to do orthodontic treatment. So this case, I treated doing full mouth reconstruction, because you can look at the lower teeth. Apart from that one premolar, they all have either dentine exposure or heavily restored teeth. They all need some restoration. So in her case, I just restored palatal surface of the upper incisors and restored the incisal edges. Patient didn't like the upper right 3 crown, so we changed the upper right 3 crown. We left that premolar as it is because it's a good premolar, there is no issue. And then restore the rest of the teeth at increased OVD. And then at the end, she was having, she was planned for implant, but then she decided to go for denture. So we gave her upper and lower dentures. And that's how this case was managed. Another case of uneven tooth surface loss, like again, you can see it's not lower anterior, yes, there's tooth wear. Upper, you can argue that there's not much going on. Yes, there is, isolated tooth wear, gingival recession, some of the leaking restoration. It's not a clear cut. It's not a case where you would say, yeah, that's a full mouth reconstruction case. Now, in these type of cases, you need to really decide how many teeth needs restoration or has old restoration, which you possibly, if you replace them with a new one, you won't be doing disservice to the patient. And as you can see here, apart from the canine and one of the premolar, rest of the teeth are restored. Upper centrals they have got quite a lot of wear. So and the lower anteriors, you can see there's uneven tooth wear. Now, in this case, if I am going to do full mouth reconstruction, then I would restore maybe 2 to 2 lower, get them in alignment with the canines, and do a lower left 5, restore them just to get curvus P flat, and then do some palatal shaft for the uppers so that the lowers can land properly on the upper teeth, and then just restore the upper anterior teeth. Yes, you can at the same time restore the posteriors, but because there is no the posterior teeth are not really opposing to anything, you could leave them as it is. In my opinion, those amalgam needs changing, but you may want to leave them as it is. So it's, it's not a hard and fast rule which ones to change. I mean, I prefer amalgam-free dentistry, to be honest. I've done lots of amalgam. They work really well, but when they fail, they really break teeth, and they fail much more catastrophically than composite. Having said that, if you don't do composite properly, you can get caries, and that's another issue. Okay, so another case, patient was actually referred to me for implant on the lower left 6 and 7 area and lower right 7. So patient had upper denture and he was happy with it. But that was the reason patient was referred to me. And he was 78-year-old when I saw him. And obviously he had a lot of tooth wear. Now you can see that on the left side, patient's got a complete crossbite. So this patient, we discussed different options. You can see that upper anteriors has got a lot of tooth wear palatally and incisally, and patient wanted to keep his teeth for longer, especially when we are doing 3 implants. We must have this kind of discussion with patient, because you don't want to do implants, restore them, and then patient's like, oh, I want to treat my front teeth, and now you increase patient's OVD, and patient will need those implants restoration doing again because they won't be in occlusion anymore. And this is something you need to really reiterate to patient whenever you are discussing treatment with the patient. So make sure that you are having discussion, even if you don't do full mouth reconstruction, you need to have this discussion with patient, because many of the implantologists, because they are just doing implant and they're not a restorative dentist, they might miss this type of tooth, or they might mention it to patient in passing, rather than really emphasizing on it that, you need to really protect what you got before you replace what's missing. And I really usually have a frank conversation with patient. Like, if patient said, I don't have enough funding, then I would say, look, whatever you were going to spend on implant, I would rather you spend on your existing teeth, because, I can't give you your teeth back. I can give you implant, which is next to natural teeth, but it's not a natural teeth. And, they have a limited lifespan, although I want my implant to be lasting lifetime, but I never tell patient that is, it will, because you never know. So make sure that you have this discussion. Again, this case is a full mouth reconstruction, in my opinion. However, we treated this case without changing that gold crown. The gold crown was fine. There was no issue. It wasn't opposing to anything. So we decided not to change that gold crown. And actually upper left 6, that porcelain, because he had a chrome framework, and patient was quite adamant that I didn't want to get it changed. And there was a receipt, as you can see on there. And the crown was sound. So we managed occlusion in a way that we don't have to do that. The good thing was that if you look at his lower occlusal plane, it was very flat, which is good. It wasn't very uneven, so it was easy to restore this one. Now this patient came to see me. Again, we'll discuss this case on the 11th more in detail. But again, this patient came to me with the chipped anterior teeth. And you can see that why the anterior teeth were chipped. It's got severe tooth surface loss. And so this case is a single arch reconstruction, because the opposing arch, apart from hygiene, patient doesn't need much. One of the premolar has a loss restoration, and there's amalgam restoration with small crack lines. So I would change them with composite. But apart from that, patient, you can get away with single arch reconstruction. And this one, possibly, you can tell that the patient's got reduced OVD, and the wear was quite aggressive, because you can see there is no dental alveolar compensation. And one of the way you can tell that there is no dental-alveolar compensation is because you can look at the gum margin, gingival margin, and they are same everywhere. So it's like a straight line. So it's not unevenness. So it's not that the lower anterior has super erupted. Another case, you can see that again, lower anterior severe tooth wear, upper anterior moderate amount of tooth wear. Posteriors not terribly bad. You can tell that there is some dentin exposure. But does it justify full mouth reconstruction? It's debatable. Okay, so the anterior is definitely, and the reason it is because patients got very restricted envelope function. So this case must have orthodontic treatment. And the reason I didn't treat this patient because he didn't want orthodontic treatment. So I said, I can't treat you because if you treat this patient in the same occlusion or the same without moving teeth where it needs to be, you will have repeated breaking, repeated fractures of your restoration. So sometimes you need to just say no. If I would have treated this patient, then I would have done orthodontic treatment, created some spaces so that I don't have to build too much anterior. I don't have to raise OVD too much, and then possibly cover those dentines on the posterior teeth. But again, as I said, they don't look terribly bad. Another case, this patient, if you look at anterior teeth, yes, there are a lot of wear. Lower anterior, there is wear, but the main issue is posterior collapsed occlusion. You can see from the side shots that patients got posterior occlusion, which is completely collapsed. Now, what can you do in this kind of circumstances? We will discuss about this a little bit more in detail later on, possibly on the third webinar about managing collapsed occlusion. But yes, you can raise OVD in this one, but it's not going to be enough to create a restorative space for you. But nonetheless, there is posterior teeth heavily restored and patients got anterior tooth surface loss. So in my opinion, again, this is a full mouth reconstruction case. Yes, you're not going to probably restore every single tooth, but you need to raise OVD and you need to really change patient's occlusion in order to do the treatment. But if you look at the threes, they don't look too bad. Lower anteriors maybe need some touch up, incisal edge bonding. But again, as I said, so you're going to do selective restorations, but you need to look at the whole mouth basically. So this patient came to see me again, guess what, for implant. Patient had upper right 5 extracted recently and came for implant. And, during assessment, I said, well, what about your front teeth? When you close your mouth, do they hurt, the gum? It's like, yeah, I mean, they don't, teeth per se doesn't give me pain, but my gum really hurts. And you can see why. You can tell the patient grinds, but also how much blanching is happening. Now, again, this patient was 79-year-old, as far as I remember. So kind of ortho was slightly out of question. It would have been very ideal to do ortho, but a patient didn't want orthodontic treatment. And maybe this is my limitation. I'm not communicating very well. Or if I see older patient over 75 that I can get away without doing ortho because I've done so many cases without ortho and I know that it would work. Maybe I don't persuade patient too much to do orthodontic treatment. In any case, we didn't do orthodontic treatment in this patient and managed restoratively by doing full mouth reconstruction. Again, you can see from the amount of tooth wear that this patient needs more than just a few teeth reconstruction. Now, yes, there are a few teeth doesn't need anything doing, but unfortunately, when you do full mouth reconstruction, you're committed now to restore almost every single teeth. Even that means by just placing some composite to make them in contact, occlusion. For this case, patient came to me because he had really severe sensitivity with lower left 6. If you look at the top left or top right photo, you can tell how thin and sharp buccal cups are if there is no cusp of buccal wall of the teeth. Now, if you look at the occlusal photos, you can tell how severe this erosion is. So patient has a severe posterior erosion and almost to the pulp on lower left 6. And problem with this case is, yeah, you can restore them. The anterior teeth are almost untouched. They look really very good. Patient's 26-year-old, very young patient. So could you do full mouth reconstruction in this case? Possibly not. So I would treat this patient with a posterior reconstruction and orthodontic treatment to gain space. And again, we'll discuss a little bit more in detail on 11th of March. But this is a combination ortho and reconstruction case. For this patient, again, you can tell that the anteriorly not terribly bad tooth wear, but posterior teeth you can see lot of dentine exposure. And it's the same case as the previous one in the sense that we need to manage it according the same way, ortho-restoratively. But this case needs comprehensive full mouth approach. When I say full mouth, it doesn't mean restoring all the teeth. You need to really do something to all the teeth. So it could be movement by doing orthodontic treatment or restoration. This case, again, we will discuss this case a bit more in detail on the day, but this patient has got a lot of tooth wear, palatally, lower anterior's got a lot of tooth wear, dentine exposure. And again, for me, this case is a clear-cut full mouth reconstruction case. So this patient is interesting. So this patient came to me for implants. As you probably would have gathered by now, I see a lot of patients for implants and then I convert them into full mouth. So this patient came to see me for implant, and because his Maryland bridges were just coming off, they didn't stay. Someone made a new one, it still didn't work. And that's usually the case. Patient needed a big block grafting in that area. The patient wasn't keen on doing that. And this quality of the bone level of the centrals weren't amazingly well. So, and he's got posterior tooth surface loss, especially the lower posterior tooth surface loss. So this case, again, it's not a full mouth reconstruction case, but it could be partial reconstruction case because the plan was to do a cantilever bridge of the centrals as a temporary measure. And when they fail, patient will then consider implants. And again, patient was young, so we decided, okay, even if we do implants on 2 to 2, we can still give him an implant supported bridge. So it wasn't in a long run that invasive treatment plan. So the plan for this patient was to restore lower posteriors, because if you look at the arch, there's a big step in the lower posteriors. So if you restore lower posteriors, raise OVD, and then use that space for creating anterior upper bridges. So then that means that I'm not going to need to drill too much of the tooth. I'm creating space for those central. And this is another way to do minimal tooth reduction or tooth preparation, because I just need to do margin. Because I raised OVD, I have already got enough space for me to all I need to do is to interproximal, just slice that area, open the contact, and just create a tiny margin. Because of his erosion, the margin is already there. So I won't have to reduce too much of the tooth tissue. And again, these cases, you need to consider partial reconstruction. But when you see wear, I want you to assess, okay, how can I restore this tooth where there is a wear? And when even many times you don't have to do full single arch reconstruction. You can do, let's say, posterior of the lowers and upper anteriors, like in this case, to close the space. And all at the end you want to see is you want a flat occlusal plane, upper and lower, as flat as you can. Yeah. Now, another case where, again, this case we will discuss on the day, where this patient has tooth surface loss. And again, it's a clear-cut case of full mouth reconstruction. Whether you do direct, indirect, or how you manage, that's a different story. But this is a full mouth reconstruction case because the amount of dentine or the teeth have number of teeth with exposed dentine. Now, this patient has severe anterior tooth surface loss, and upper and lower, there is not many posterior teeth left. And then, so again, I would consider treating this comprehensively because it would be easy to manage occlusion, treat all the lower teeth. Patient didn't want his bridges or the crowns to be touched. They were implant-supported crowns. And patient didn't know which implant it was. So we decided to treat this conservatively with the teeth-only approach, not touching the crown. But you can easily do that if you know how to redistribute spaces. So that you will create space by increasing OVD, and then you need to redistribute that space using upper or lower or both teeth. So in summary, when you are considering single or dual arch reconstruction, you need to consider that if you see a lot of tooth wear, a lot of number of teeth have got exposed dentine, number of teeth needing restoration. So let's say after 28, 27, or 25 teeth needs restoration, then maybe consider increasing OVD, because if you do that, you will create restorative space, which is very vital. Localized tooth wear, but you have lack of space in that case as well. Like I showed you the case where the lower posterior tooth wear, but we didn't want to touch anterior teeth. In that case, you can consider partial reconstruction. If you're doing orthodontic treatment for a case which has got heavily restored dentition, then you can really create space by doing ortho for your new restoration. And this is something you need to discuss with patient, that I'm going to straighten your teeth, but at the same time we can create some spaces for those difficult restoration on the sevens where you don't have restorative spaces. And it would be good discussion to have with the patient, not just straightening teeth, whitening, and edge bonding, but look at a little bit more comprehensively. And again, as I said, orthodontic treatment is a type of full mouth reconstruction because you're changing everything. If patient has a traumatic occlusion, like I showed you for that older gentleman, consider orthodontic treatment. But many times when you consider orthodontic treatment, you are going to have to kind of consider restorative treatment as well, because usually when patient has traumatic bite, patient will present with a tooth wear. So you would correct the occlusion, but then the tooth wear is not going to correct by itself. You'll have to still do something about the tooth wear. And when you're treating collapsed posterior occlusion, you again can increase OVD, or you can be more creative when you are doing full mouth reconstruction or single arch reconstruction in order to create space for your restoration, and combination of any of the above.
So I hope you found this very useful, and I hope I have helped you in understanding that tooth wear cases are not the only cases for full mouth reconstruction. There are lots of reasons why you want to do full mouth reconstruction. And one thing I see or hear from my previous delegates more and more is that once they know the process of full mouth reconstruction, they are really seeing a lot more cases than what they initially thought they had. So if you really want to learn simplified way to do full mouth reconstruction or complex cases, then you must join me in my Full Mouth Reconstruction Summit 2026. It's only for £95, and there are tons of benefit of joining that, including free communication course, free photography course. But more importantly, you will hear from dentists like yourself who may not be doing full mouth reconstruction, showing or sharing their first full mouth reconstruction case. And that really helps in understanding what kind of struggles they had and what to look out for when you're doing first full mouth reconstruction. So again, I look forward to seeing you at my FMR Summit 2026. Scan the QR code or type in the link and book the ticket before it gets completely sold out and before you lose your early bird discount. So again, thank you very much for sticking around, and I hope you enjoy this webinar, and I will see you in 2026.